just have one of us show up next time and answer questions and not have to be live every time. Yeah.
Sounds good.
So I don't know if mine is showing. It may be showing my daughter's name, Rain Parr, but it's Mara Hamrick.
Hey, Maura. Long time no see. I thought you
Dave.
looked familiar. Good to see you.
Well,
Hope you're doing well.
Good to see you too.
Thank you.
Yeah.
Thank you for telling us that. Ginger would have been going crazy trying to find Dr. Parr.
I know. Absolutely. Yeah.
We have somebody else who's joined us. Name's Kate. Just that's only listed as Kate. What? Could you identify yourself a little more for us, please?
It's Kate Timberlake. I'm with Eagle Brassfield.
Hello, Dr. Timberlake. Nice to talk to you. All right, we're going to get started in a sec. So Dave, why don't we, I'll go ahead and do the first half here, and then maybe well, what we'll do for other people that add that we can't identify for sure, we will take care of those at the end of the meeting. Okay?
Sounds good.
Yeah.
Okay.
So after you get through talking. Yeah. All right. Good evening, everybody. Welcome to the THN New Provider Orientation Session. We are so happy you've joined.
Oops.
Get started here. If your name is showing up appropriately in the list, then we'll be okay. But if it's not, if there's a first name only or a telephone number, we will ask for further identification toward the end of the meeting. Okay, Ginger, I once again ask, could you put everybody on mute?
Yeah, I will. Hold on a second. Let me meet you when I do this. Hold on.
I can unmute myself. Great. Good. Thank you, Ginger. All right. So I'm going to share my slides and get started with us tonight. I'm going to talk for the first half of the evening, and then Dave Grapey, our medical director for value care and for specialty care, will be doing the second half of the meeting tonight. So let me get myself going here. Hello. There we go. Be sure you're looking at the right one. Yep. All right, good. So as I said, this is our THN New Provider Orientation, and we do have a series of topics for you tonight. We're going to talk about why Triad Healthcare Network exists, what's the goal of THN, how it's structured, a little bit about how it all works, because it's important to understand when we ask you to do certain things, whether you're a primary care physician or a specialty physician, why we are asking you to do that. So we want you to understand that. A little bit about our history, and then I'll finish up the first part talking about the role of primary care physician. Then Dave's going to take over, talk about the role of the specialty care physician. He's got a number of other things that are just a number of topics that he'll hit on toward the close of the meeting. So the reason Triad Healthcare Network exists can really be summarized in just a few slides. The first one is for us to look at healthcare costs in America. And this is not new news to you. These are the healthcare costs of America in 2018, roughly twice that of the nearest Western country, substantially higher than any of the second and third world countries. And so we spent a lot, and this is not new news, as most of you know. If we look at healthcare spending as a percent of GDP for the last 40 years, we see that it's been rising steadily. I always enjoy looking at this and pondering what happened during all this time. The first thing I always like to note is I actually became a physician in 1983, so apparently this entire process is my fault. I'm hoping that's not quite true, but it did start. But actually, it didn't start right then. If you look back in the 70s, you would have seen a straight line going up, or a sloped line going up, I should say. And so that led to the first effort to control healthcare costs in America, and that's when DRGs were introduced. Things broke through, though, in the 90s, of course, for those of us who were old enough to remember, was the period of managed care. I've actually never really for sure identified what this process is, but this is the bright side of looking at this, or the optimistic side of looking at this, is that that's the Affordable Care Act and the development of accountable care organizations, but it's more likely the Great Recession, or maybe some combination thereof. And it wouldn't be such a big problem that we spend a lot of money on healthcare if we had quality that matched it. But you also know that story as well. Here's a graph of life expectancy at birth over the same time period. And you see that while Western countries are generally going up, ours is flat, and even in the last few years going down. Similarly, if we look at a series of health outcomes, life expectancy at birth, which we've already looked at, infant mortality, unmanaged asthma, unmanaged diabetes, safety during childbirth, we don't do very well. Now, I have no idea why it's dangerous to have a child in Canada. I'm a little surprised at that one, to be honest with you. But all the other ones kind of make sense as being the lower numbers there. But the reality here is that we do not do well on a lot of things. Now, we do well on heart attack mortality, and we do well on cancer care. So this is the story of American healthcare, right? High technology, highly complex care. People come to the United States for that. But if you have just normal stuff, we're not such a great place to be. And of course, as I said, many of you know that. So why do we get such poor results when we spend so much money? And it's because of the way the system is designed. And that's not what people intended to happen, but every system, whether it's your financial system in your home, or your system for taking care of your car, or your system for whatever you do, every system is perfectly designed to get the results it gets. And if you want to change something, you got to change the system. And Dr. Batalden from Dartmouth said, if we keep doing what we've been doing, we'll keep getting what we've always gotten, which is this healthcare system that's expensive, inefficient, and high tech. So things need to be redesigned. But what about it needs to be redesigned? Well, there's probably two main areas to think about when we think about design of the healthcare system that's a problem. And the first one is fragmentation. We are in, as you all know, highly siloed organizations. We're going to talk about that some more as we go through the evening. And part of what THN is ultimately trying to do is to overcome some of that fragmentation. But we don't form, as Dr. Berwick said many years ago, we don't seem to form the coalitions and communities we need to make progress, because the structures and the finance is in the way. So that's one thing, it's fragmentation. But the other thing that's interesting is variation. And there's a lot of variation in healthcare. Again, many of you know this. I think this is a great slide. Let's walk through it a little bit just so we understand. This is the percentage of people with uncomplicated joint replacements who go to skilled nursing or inpatient rehab. Now, it's a bit old. The data is old, 2012 to 2014. So the numbers probably aren't this high now as they were. But notice that we had organizations where 18% of people went to skilled nursing, and organizations where 95% went to skilled nursing. You know, just as an aside, when I need my hip replacement, don't send me here if you don't mind. I'd rather go to one of these, because I really don't want to go to a skilled nursing facility unless I have to. Now, for those of you new to Greensboro, you might not know this, but we have been spending less than average for Medicare for years. When we started THN about 10 years ago, we recognized that we were spending about 15% less than average for the average Medicare patient on a sex, age, gender, age, and severity of illness basis. In other words, controlling for all that, we spend a lot less than everybody else. So to me, you know, when I look at this, if I think about healthcare spend, I think these people out here like Miami and Houston, where they spend 60% more than we do on an annual basis for care. And we're down here, so if they would just get their act together, we'd be okay. But what's sobering about this is that you see that even in the best systems, there's a lot of variation. So here's a system, again, just looking at uncomplicated joint replacement. We've got a great system that's doing well, but there's still a lot of variation. There's one organization within this health system that's still doing about 90% of people going to skilled nursing. And when we look, and we're just beginning to be able to do this, but when we look at what we do within THN, within our providers, within our network, we see a lot of variation. Now, the problem with variation is that it's almost always bad. It's almost always bad care. These people are likely to be getting care that they don't need, and it's expensive. And some of these people are probably not getting the care that they do need, and that's expensive as well. So the point here isn't to say we should do less. The point is that we should do right. And what happens when we decrease fragmentation and decrease variation is that we get higher quality and lower cost care. And that's really what THN is all about. We're trying to improve the quality and lower the cost of care in concert with the fine work that all of you are doing and you will be doing for the rest of your careers while you're in Greensboro and working with THN. Now, if we take quality and cost in this way, and you say, well, let's start with quality and let's divide it by cost, you get this thing called value. And that's the big buzzword today. We're trying to provide high value care or reduce low value care. And so, again, a lot of what we do, and Dave's going to talk about this more toward the end of the meeting, is a lot of what we do is try to increase value, which means to either do it better or do it for a lower cost. And that cost might not be a unit cost. It could be a bundle of costs. It could be the cost across an entire episode of care. Not that each thing is less, but we don't do as many things to as many people. And one of the things I always like to point out when I think about quality for people as old as I am is that quality includes patient experience. Those of us who are old like me we're not trained to think about patient experience as being part of quality. And of course, it is an important part of quality. And as we'll explore later, we're being measured on it now, and it will be more important in the future. So that's our goal. It's really simple. We came into being because the healthcare system is not in great shape. Cone Health had the foresight to realize that. Commissioned a couple of physicians to get a group of people together and start to work on this, and the result has been THN. So what is THN? It's called an accountable care organization. You could call it a physician hospital organization, but those are words from the 90s. So we're an accountable care organization. Accountable care organizations came about because of the Affordable Care Act. It's one of the things that was in the 2,000 plus pages of the Affordable Care Act. Many people, when they want to say bad things about the Affordable Care Act, are not talking about accountable care organizations. I'm fairly confident that no matter what happens between the Supreme Court and Congress, that nobody's going to get rid of accountable care organizations because everybody agrees that we have to move more toward value. THN is the collective effort of employed and independent physicians. So all of you tonight are our independent group. We have regular meetings like this with the new physicians and providers who are employed by Cone Health. And so about half and half, as I'll show in a moment, of our docs are employed by the health system and half of us are independent. I am an independent physician. I work in a group called Eagle. We are physician-led and professionally managed, which means we have lots of physician leadership, of which Dave and I are two, and there are others. And there are many, many people involved, many physicians involved in the leadership of THN and committees and various other structures we have. But we're professionally managed. We have excellent administrative help and leadership on the administrative side. So if we were to think about THN and how it relates to these groups of people, we've got Cone Health, and THN is part of Cone Health. But a little bit of THN is not part of Cone Health because part of THN are these independent practices, and we are not. Obviously, you're not employed by Cone Health. But all the providers that are employed by Cone Health are in an organization called CHMG. And I've lived here long enough for people to get this confused. If they even know what THN is and CHMG are, they often do tend to get them confused and think they're the same thing. And roughly speaking, we have about as many people in CHMG as we do in independent practices. I tell our CHMG colleagues when I meet with them on a regular basis, the new providers there, that one of the big implications of this, and if you talk about fragmentation, is that CHMG is basically on one EMR, and called Epic or Cone Health Link, and virtually none of the independent practices are. There's one small independent practice that's on Epic. But we are already having to deal with this fragmentation. We have 74 different EMR practice combinations within THN. And so part of what we struggle with is trying to overcome some of that fragmentation. And I tell our CHMG colleagues this because they can't be thinking that just because they send a message through Epic that's just necessarily going to get to their independent colleagues. So I try to be sure that we all know that. But similarly, we have to work hard to communicate with them as well. So that's a little bit about the overall structure of THN. So how does this all actually work? So basically, this is our business model. Practices, health systems, and other entities are paid fee-for-service payments, or in the case of Cone Health, perhaps a DRG payment, for the care that they provide. So the care is delivered and is paid for by some payer. And we have, by the way, 9 different contracts with different payers, ranging from CMS directly with what's called the Next Generation ACO to 4, I believe, Medicare, maybe 5 Medicare Advantage plans and some commercial plans. But the care is delivered and paid for by payer. And at the end of the day, the total cost of care is compared to some negotiated THN target that we have. And so if that cost of care comes in less than the target, that's good news. That's why it's green. Payment comes from the payer to THN. However, if the cost of care is above the target, it's red. That's bad news. Payment goes from THN, actually from Cone Health, to the payer. So we do not require that our physicians pay if we are in a deficit situation. Cone Health has supported us throughout our organizational life, and I'll talk a little bit more about that in a moment. But we really need for this to stay green. Okay, we really need to stay all of these to stay green. Now, if you think about this in a more colorful way, you can think about pizzas. All right. So our goal is to increase the pizza pie. We want the pie to get bigger, and there's some things to do that by increasing that target that I was talking about. One is called RAF, which I'll talk about in a moment, quality, which includes gaps in care and surveys. But also, we don't want to eat too much of the pie. We want to control the cost of care, so we want there to be timely, appropriate, coordinated medical care. And we also have to control the amount of overhead that we have in THN, because we do employ a lot of people. And so if we do this, then we get leftovers. And the great thing about leftovers is that we get to distribute those to our physician partners and to our health system partner. And that's really the goal of what we're trying to do. Lower the cost of care, improve the quality, and help our doctors and other providers succeed in this really strange world. Now, I do want to observe to you that there's a lot of money going through this organization. We have 185,000 patients in risk or shared savings contracts, and that represents $800 million in medical cost spend on our population. And that's not even everybody in Greensboro. So $800 million. So if we come in above the target, that's a good thing, but we come in below the target, it can be a bad thing. And it doesn't take many percentage points either way to make it really good or really bad. So that's why we want, one reason that we're actually having our session tonight is we want you to understand what your contribution and your role in helping us be successful, because there's a lot at risk. Now, it hasn't always been this way in THN. We started in about 2010 to 11, and we thought we were going to do some simple pay-for-performance pay-for-performance type contracts with some commercial plans. But in the statement of Field of Dreams, you might build it, but they might not come. So they didn't. But about that time, CMS came out with the Medicare Shared Savings Program. And we quickly shifted from worrying about pay-for-performance to a thing called population health, where we're now worried about the cost of care and the quality of care across a population of people, not just the people that are right in front of us. So we started in the MSSP program. 2012 to 2014, we continued that strategy, and we started to think about taking on risk. We were in MSSP Track 1. We made money the first year we were in existence. We thought all this stuff was really easy, but boy, we learned later it wasn't. And we did also have an HMO contract with Humana that was a risk contract. And we started the process of quality metric gathering and analytics, and that's through a vendor called KPN. Many of your practices are connected to KPN, so we get quality data out of your EMR directly. For a few of you, we haven't been able to connect yet. We're working on it. And sometimes we have to do it in a more manual fashion, but we've been working on that for 7 or 8 years now, and you can see that. In 2015 to 2016, we continued to do more risk. We became a next generation ACO. We moved from the Medicare Shared Savings Program to a next gen ACO. What that means is we're at 100% risk for about 28,000 regular Medicare patients, red, white, and blue Medicare patients. We developed contracts with United Healthcare for risk. And Cone Health actually started its own Medicare Advantage plan, Health Team Advantage. After that, over 2017 and 18, we tried to develop some other risk models. One of those was with Medicaid. That never came to fruition because of a lot of things. But we're not in the Medicaid risk business at this point, and I'm not sure we ever will be, given the way the contracting's evolved from the government, from the state government. But we did develop some commercial shared savings contracts. And over the last 2 years, what we've really been trying to do is to get better at what we've been doing. So we are trying to improve our improve our revenue, increase our revenue by improving our results. We've started a program called Elite Primary Care, which is a program where we have our medical directors and our staff trying to be closely related to our primary care offices to help them get better at quality and at cost of care issues. We are, whereas before we had a vendor called KPN to help us analyze quality, we now have a new vendor called Innovacer who's going to help us monitor and report on the cost of care utilization and some other quality analytics. So we're very excited about this. This will be implemented, it's just started in the last 2 months. It'll take us probably about a year to get this completely up and running, but you can look forward to some really insightful data and information from Innovacer in the future. And what's the future look like? We call it upward and onward. We're going to try to increase our success under our current contracts, and we may even think about expanding with other providers in the state. Because although we are hospital-owned, although THN is hospital-owned, this is a strongly physician-led organization. And that is very appealing to lots of people in the state who don't look at us as a subsidiary of Cone Health, but look at us as a leader in physician leadership in the process of accountable care organizations. Now, this didn't come without some effort and cost. So this graph shows you the amount of money that Cone invested in THN over the years. As I said early on, we made some money, so didn't have to get much, but subsequent to that, you can see that we had an ever-increasing net investment by Cone, finally topping about $19 million at the end of fiscal year 16. But notice what's happened here. It's coming back up, and I'm happy to report that the reason that you don't see the bar right there is because there's nothing here. We are now, let's see, what's today? Is today the 30th or the 29th? Today's the 29th. Tomorrow, as of tomorrow, we will have paid everything back to Cone Health at the end of this fiscal year. So that's pretty dazzling. We're pretty pleased with that and very happy that we've been able to repay our the organization that got us started in just 4 short years. We did not think that would be the case. What's driven that is our increase in revenue. And you can see that over the years, we've had a pretty steadily increasing revenue. Fiscal year 19 was a little bit lower. Fiscal year 20 is going to be good. Now, there's a funny thing about the revenue in THN. Revenue in fiscal year 20 actually was based on the work we did in calendar 19. And similarly to what happened in what we get paid in fiscal 19 is mainly from 18 and stuff like that. So you know, to tell you the truth, we're having a great year this year with COVID because many of our practices have not been as active, and that's not even reflected in this. So we have had some very strong performance in the last few years, and that's led to the reality that we've been able to give ever-increasing incentive payments to our providers. So we've had a steadily increasing payment of incentives, and this past month we just paid out $9 million in incentive payments from THN. In addition, by being a member of THN, if you take care of Medicare patients, then you are paid a 5% bonus for participate from CMS because you are in THN. If you weren't in THN, you would have to do this thing called MIPS, the Merit-Based Incentive Payment System, which would be a lot of work. And last year, the best people in MIPS got 1.8%. So you get 5% just for being in THN. And we think this is somewhere probably closer to 6, maybe even a little bit higher than that in terms of revenue for our practices. So we're very happy with that, and we work hard to make sure that maintains itself. We think actually the incentive payments for 2020, and one of the reasons you're in this session tonight is to be able to qualify for some of those incentive payments, is going to be north of $9 million. Now, I would say, by the way, that incentive payments are not paid directly to physicians, nor are AAPM bonuses. They are paid to the tax ID numbers of the physicians. So these come to the practice and not directly to physicians. So I do want to be clear on that. So that's some of our history. That's where we are. That's our business model. That's what we're trying to be successful at. So let's dig in a little bit more and think about roles of different types of physicians and then more detail on some of the aspects of what we're trying to do here at THN. So the first thing I want to talk about is the role of the primary care provider in THN. And the reality is that the first thing that happens when we have a PCP is we get a patient. If we don't have any PCPs in THN, we don't have any patients, and therefore we actually don't have a network. We don't have an ACO, because every payer tracks the attribution of patients to an ACO by the attributed PCP of that patient. So the first thing that's really critical is that we don't have PCPs, we don't have patients. So PCPs do get the lion's share of the incentive payments because of this fact, and because of the fact that they're responsible for closing most of the quality metrics, and they're responsible for probably at least 80% of the RAF diagnoses. So I'm going to explore those last 2 points here as I close my part of the evening. The first is quality metrics. Quality metrics affect that target. Remember that target I was talking about the pizza? We want to make the pizza bigger. So the quality metrics affect the budgeted target in almost all of our contracts. In some cases, they basically function as a synapse. If we don't get them, if we don't hit those quality targets, we get $0. If we hit the quality targets, we get millions. So those are really those are really important quality metrics. For some of them, they just float the target up and down a little bit, not necessarily an all or nothing, but they do affect the actual target. So what are these quality metrics? Well, some of them are HEDIS metrics, things like, did you have a colonoscopy? These are the right age people, of course, and all that. Did you have your colonoscopy, mammogram, pap smear, just on and on, those kind of quality metrics that we all know is part of really good well care for our patients. It also includes a series of CMS Part C metrics, which are medication adherence. And that's not a typo, that's not a Part D. It should be, I'm pretty sure it's Part C. And these are medication adherence metrics that are critical. So we actually get measured on how well our patients fill their prescriptions and take their medications. Hard to believe that we get measured on that, and we work hard to help our patients succeed. The thing that's really becoming more and more of an emphasis are surveys. So we are being surveyed right and left, and some of those are JCO and some of those are Haas surveys. And this next part of the slide will show you that right now, HEDIS metrics make up about 27% of our target, pharmacy metrics about 15%. But over the next 4 years, or in the next 4 years, and we're halfway through it, CAHPS and Haas surveys move from being 29% up to 36%. So we have to pay special attention to this, and surveys are really hard to drive down those results and understanding for our doctors at the doctor level. So we have to work on that, and we'll be working with you over time to do it. And then finally, let me speak just for a moment about risk adjustment factors, because this is absolutely critical. In fact, one of the other 2 things that you have to do to meet your onboarding requirements, one is to watch a audio PowerPoint on RAF, and I think the other one's on surveys. The one on RAF's almost finished, so we'll have that posted soon, and you'll be able to go into more detail. But basically, let me just quickly say that Medicare Advantage plans contract with CMS, and they provide a health insurance benefit. That's what they are. And that Part C I was talking about is actually Part A, which is hospital, Part B, which is physician, and maybe Part D, which is medications, and Part C is what we call Medicare Advantage. Now, if you were going to contract with Medicare to take care of patients, who would you want, sick or well? Well, everybody would pick well, right? You don't want people who are going to cost you a lot of money. So the result of that is they created a system called the risk adjustment factor system. And so you could imagine this as a seesaw, that sicker patients are weighting down the results of the Medicare Advantage plans, and less sick patients don't weight it down so much. So what risk adjusting diagnoses do is that creates a lift, if you will, on the sicker patients, because the Medicare plan gets paid more, and we're at risk with the Medicare plan, so they get paid more for those patients. And again, we'll go into great detail on this in our RAF 101 presentation, which you will need to be watching. But I just wanted to outline briefly what this is. Now, what is the effect on THN? It's enormous. Again, we have a lot of lives at risk. We have 85,000 Medicare and Medicare Advantage lives. If the premium for those is about $750, which it is, then a 1% change in RAF is a difference of $7.5 to $8 million. So a big effect. So that was a lot to go through real quick, some background and the role of primary care docs. I'm going to turn it over to Dave now, and he's going to take us on to the end here.
Thank you, Jim. My name is Dave Gravy, and I want to add my welcome to you all, and thanks for participating in this. I serve as one of the medical directors for THN, specifically around value-based care and also for specialists, and also have a role as the chief medical officer for a Medicare Advantage plan called Health Team Advantage, which is owned by Cone Health. And prior to that, I practiced for 25 years. I really had a wonderful career here in Greensboro at Alliance Urology as a urologist. And I've been in a full-time administrative role now for about 2 years. So let me go ahead and start my part of the presentation. Jim, can we see the full screen okay with the slides?
Yep, you got it now. Yep.
All right, perfect. Thank you all. So tonight I'm going to talk a little bit about how do specialists fit in this. And so if you're a specialist, then this will pertain to you. If you're a primary care, you can better understand how specialists fall into this ACO world. The importance of network fidelity and keeping patients and the work that we do within our own network and not into the hands of the academic medical centers. How we do that through some management of referrals and the things that we've done over the last couple of years to improve that process. I think it's always helpful to understand where we spend the money, where's that cost of care, where are opportunities. I'm going to touch a bit on low value care and go back to this idea of care variation, and then a little bit about how specialty physicians are incented within our plan. So when ACOs came around, and to this day, most of these alternative payment models are fundamentally set up to favor around primary care. In fact, for most of these models, you don't really even have an ACO, or you can't participate if you don't have primary care providers. Now, there are alternative payment models and other value-based contracts that are directed at specialists, but for the most part, this has been very centric towards primary care. When we started THN, we wanted to be completely inclusive. And we felt that it was important, if we were going to work as a community, that we would include all physicians. And at the beginning, it was very challenging to find what the value would be and to ask our specialists to really participate as we got our feet wet. It's become evident to most of us that there is a strong role for specialists in value-based organizations such as THN. There are a lot of common high-cost diseases, COPD, heart failure, diabetes, where there is specialty input, or in some cases where the specialist may be providing the primary disease management for some of these conditions. Clearly, we need to have collaboration and coordination of care. We're understanding that patient experience of care is so critical. And since specialists are 2/3 of our doctors, we have to have them participating in trying to improve this for patients. There are many specialists who do have the ability to increase our risk adjustment scores, especially if you're in a specialty where there are a lot of conditions that you would imagine would add to the cost, like cardiology, neurology, pulmonology. But one of the downsides to including specialists is at the end of the day, when you have a pile of money, you hope that where you've been able to effectively save money and hit quality targets that provide you with extra incentive monies, that you want to distribute that to your physicians. And again, we have 2/3 of our ACO is specialty physicians. And so we have to strike that right balance between rewarding our primary care doctors, who are clearly burdened with the majority of the work around quality incentives and risk adjustment, versus what we need to do with specialists. One of the real places specialists can bring substantial value, and we have not begun to really tap this, is around this idea of low value or no value care. There's really nobody who would disagree with the statement that at least 20, if not 30% of the healthcare that's provided in this country, whether it is testing, medications, various procedures, really provides very little value. And so if you think about, again, that we're close to $1 billion in healthcare spend on just our, really for the most part, Medicare book of business, then you're looking at 200, potentially $300 million of opportunity. And much of this can be driven and should be driven by specialists. Again, the pizza pie model, the primary care physicians and their attributed patients give us the pizza, the risk adjustment and the quality outcomes increase the size of the pizza. But how we spend that money obviously ultimately lets us know how much we'll be left with at the end. The other thing I think it's always helpful to think about a primary care, and this is true whether you're a primary care physician or a specialist, that a primary care physician, when you think about their panel, and it can be anywhere from maybe 600, it might be 1,500 patients, depending on what the mix is. But if you add up the healthcare costs for their panel, the average PCP really is a CEO of a $10 million healthcare enterprise. And traditionally, of course, primary care physicians were paid, 2 to 4% of that potentially. It's certainly increased over the last several years. But the vast majority of that $10 million was spent providing healthcare that was really, and many times was not completely under the control, and still is not completely under the control of primary care doctor. But as these models have evolved, we've started to learn how we best approach that collaboration and how to think about that. And of course, when I was coming out of residency, that it was very popular to have HMOs with really strong gatekeeper models, and the whole idea was just keep patients away from specialists and we'll save a lot of money, but you lose that co-management, you lose that expert care. And then when HMOs went away, we went through a period where there really wasn't much around referral management. There was certainly none of these concepts of a high value specialist. Many times primary care doctors sent patients to old classmates, somebody who went to your alma mater, maybe somebody who was in your journal club, or certainly, and rightly so based on reputation or patient experience, without doubt. But now more and more primary care doctors need to consider who are high value specialists. And the idea we've learned is that keeping patients with complex and medical problems that require specialist input doesn't serve anybody any real purpose, and it certainly doesn't provide good care. What the goal really has to be is to find specialists who do really ascribe to this high value idea of doing the appropriate amount of testing, the appropriate amount of treatment. And most studies would show that if in ACOs, if patients see that sort of Goldilocks amount of specialists, it's much better for the patient and the ultimate financial outcome than too few specialists or too many specialists. The other thing that's really important when we think about a network like THN is this concept of network fidelity or keepage. Once we have patients that are part of our network through attribution with our primary care doctors, it's really critical that as much of the care that we can provide to them is kept within our network. And that's for a lot of reasons. Of course, most of the time, one of the big issues is cost. So if a patient seeks care and has a joint replacement, for example, at Duke instead of Moses Cone, that DRG, the cost of that care is going to be considerably more than if it were performed at Cone Hospital because of the difference in reimbursement that's afforded to academic medical centers. So it's more costly care, but then that care and that revenue is lost to the providers and physicians that are part of the network, and the hospital system itself loses that revenue. And we've estimated, before I say that, historically about 20% of the healthcare within our community leaks out or is not kept within the THN network. And a lot of that goes to the 3 academic centers. Some of it does go to some other smaller regional hospitals. But for every 1% of that 20% that we can recapture, that's $4 to $6 million in revenue that then stays within our network. And there are a lot of reasons for leakage. Access is a very key issue in some specialties in our community and in primary care. And not every area of Greensboro do we have enough providers. There are also and have been historically referral process issues. At many academic centers, it's a single phone call that you can use to get your patient referred. Historically in our community, that meant a phone call, and every specialist had a different approach or way that they wanted their patient referred. And so it was a very cumbersome process that made it difficult. And the 1-800-EASY button for the academic referrals is a very competitive advantage for them. Of course, there are patients who prefer that. There are some legacy referral patterns, and we haven't always done the best job marketing the importance of staying within the THN network and how we better coordinate and collaborate on care. So network fidelity for a network like us is really critical because, again, care provided outside our network is more expensive. That revenue is lost to Cone Health providers, to independent providers, and to Cone Health itself. And the care can be more fragmented. There is certainly a loss of the ability to do a better care transition. There's some loss of analytic data. We share a lot of information, and when a patient goes outside of our system, we lose that opportunity. So this is something that we work very hard on. One of the ways we do that is that about a year ago, we put in place a referral management system called Proficient Health after evaluating several different systems. And using this system now, our providers can refer patients within our network, understanding who is in network, and we can do a much better job of understanding where patients are within the referral process and ultimately closing the loop to make sure that the referral has been scheduled, it's been performed, and the notes returned. So this has really been a critical and we think very important part of working cohesively as a network. With that, of course, we get some data, and this is a busy slide. We will send the slide deck out to you so you can take a look at this, but these are the kind of things that we try to keep track of. Within the specialty world, about, again, collectively 20% of the 21% in 18, 20% in 2019 of the patients get their specialty care outside of our network. It varies quite a bit by specialty. And so we keep track of this. We like to see how it's trending over time. We hope that we're making positive gains and not the red boxes where we've lost some ground. But this is the kind of thing we monitor, not to be punitive, but to give specialists opportunity to improve this. How can we work collectively to try to make access better and provide that care within our own community? Likewise, we like to look at primary care. Primary care docs cannot completely control where their patients go, especially if the patients are in traditional Medicare and are not in any type of HMO, but they can influence patients. And so we like to give kudos when kudos are deserved. And so in this particular scorecard that we presented and socialized, we highlighted the independent groups within our THN network that were doing the best job of keeping their attributed patients within our network for admissions to acute care facilities. So again, if it averages 20%, these are all practices that were averaging less than 15%. So these are the kind of things that we do need to monitor. We need to help our lower performing groups improve. And we certainly like to show off the groups that are doing a great job. Now, one of the things that I always think is really important and something that I was really quite naive about all the years that I practiced medicine is really, where does all this money go? What do we spend it on? And can we spend it in a better way? It's not all about just saving money so that we all can have a higher incentive. That's part of it. But by taking money out that's not contributing to the actual health or the quality of life for some of our patients and putting that money into services that do provide much more utility is really critical. And it always baffled me that physicians don't feel that they have any responsibility really with regard to the overall healthcare spend. And so several years ago, there was a study of I believe 2,000 to 3,000 physicians who were asked who really needs to take primary responsibility for reducing healthcare costs. And this was an article in JAMA. And trial lawyers, insurance companies, hospitals and health systems, pharmaceutical companies, and device manufacturers and patients all were felt to have a greater responsibility than physicians. Now, I certainly don't feel it's physicians' sole responsibility to do this, but I would hope that docs would take it upon themselves to really look at what we spend our healthcare money on, such that we can keep a larger percentage of that to the providers who do this work, but also to provide higher quality services, more higher value services to our patients. So Jim talked a little bit about some of our benchmarks and our membership. So what we call the next gen which is the ACO members that we have that have traditional Medicare. They're not in a Medicare Advantage plan. And we have about 27,000 of those through attribution with our primary care doctors. And in that 27,000 members, we have, it's not quite 300 million, but it's close to $300 million of spend. That's our benchmark. That's what the government says, hey, that's your target, guys. You go over that, pay us back. You go under that, you keep the money. So we have to understand where that money goes. How do we spend that close to $300 million? And so this is a busy slide. We won't go over this whole thing, but what I want to do is kind of just highlight a few things. So the average next-gen ACO member, we spend a little over $9,000 on average per patient per year. Of course, some it's zero, some it's $250,000. But of those 27,000, that's, if you do the 9,000 times the 27,000, it's a little less. This is for the non-duals, which mean these are the patients who don't have dual eligibility with Medicare and Medicare, Medicaid and Medicare, who are more costly, or the end-stage renal disease patients that we also have. So the math doesn't add up exactly, but it's very close. In that, of that $9,000, we spend about a third of it on inpatient admissions, both medical and surgical. The big four are sepsis and heart failure on the medicine side, and knee replacement and spinal surgery on the surgical, more elective admission side. 10% of our care is really to the post-acute, to the skilled nursing facilities and home health, office visits and specialty outpatient surgery, office procedures, about 17%. Lab testing, radiology, 5%. This really surprised me that infused and injectable drugs were 12% of our overall spend, and then a variety of other things, including ER medicine, hospice, and some DME, for example. Now, when it says, for example, sepsis, $277, that means on average, for all our members, we ended up paying $277. Of course, in reality, it was either zero or it was about $15,000. But if you add up the amount of money that we spend on sepsis and extend that beyond just the next gen to our 80,000 Medicare members, we spend a little over $20 million a year treating sepsis. And so you can imagine for all these conditions, it's a substantial amount of money and a lot of opportunity if we can come up with cost-effective ways to either avoid some things or to consider alternative therapies that might be less expensive, or to manage things better, like heart failure. Now, of these numbers, some of the things that were interesting. So office visits. So if we talk about just office visits to primary care and specialty physicians, that was only 6% of that total spend, almost equal between primary care and specialists. We spend a tremendous amount of money on patients in the last 12 months of their life. Some of it clearly appropriate as we try to save patients who have complex illness, but I suspect quite a bit of this average $13,000 that we spend in the 30 days preceding death is wasted, and because we haven't discussed palliative care, hospice, advanced care directives, etc. I found it fascinating that we spend twice as much on injectable drugs like chemotherapy and immunotherapies and other Part B drugs than we did for all the PCP and specialty office visits combined. And then we spent more on hip and knee replacements and spinal surgery than we did treating all the sepsis and heart failure. So numbers to consider. I always find it fascinating to start to really think about where the healthcare spend actually goes. Now, Jim touched a bit on low value care. We talked about fragmentation and variation. So with that, obviously, you can add duplication, where we don't know that the doc down the street did that exact test a couple of weeks ago, unnecessary care, inefficiencies, etc. This all reduces quality, and you end up with low value care. Now, Jim gave a little example, gave a big example about skilled nursing after joint replacement as an example of clinical variation. One of the cases I found fascinating was from a group called Improving Wisely. Improving Wisely is similar to Choosing Wisely. This was started in conjunction with a nonprofit organization and one of the leading surgical oncologists at Johns Hopkins. And they took publicly reported data to look at some variation within healthcare. One of the things they looked at was re-excision rates after a lumpectomy for breast cancer. So there's been controversy, or there was controversy for a number of years after lumpectomy as to what constituted a safe margin. So there were some physicians who felt you needed 5 millimeters of margin, some 2 millimeters, some possibly less than that. And historically, about 22% of patients who underwent a lumpectomy had to go back and have a re-excision because of concerns over the margin status. There was a consensus by oncologists and the surgical oncologists and the radiation oncologists that as long as there wasn't tumor right up to the ink, you could consider that a safe margin. And over the next few years, the re-excision rate went from 22 to 17%. Now, none of us really feel like we should be practicing cookbook medicine and that we shouldn't have some clinical judgment in our abilities to practice medicine to some degree how we'd like to. But there is a certain amount of acceptable variation, and then there is clearly unacceptable variation. And so when they looked around the country at what the excision rates were, it ranged everywhere from 2 physicians who had 90 to 100% re-excision to a number of physicians who had 0%. Now, 0%, it's hard to know what this means. Does this mean that they are such fantastic surgeons that they always get the tumor? Are they excising way too much tissue in order to assure margins? Are they just not even really caring? And on this end, how do you explain having to take back 90% of your patients? And so at some point, you have to say that if this average is 17% here at the longest bar, then certainly we're going to accept people on either side of this and maybe even a standard deviation here or there. But there is a point where variation just cannot be considered acceptable. And this has to be socialized, publicized, and patients, as well as referring physicians and other people within a healthcare system, need to know what these outcomes are so they can make the best judgments. There are a number of things that we look at with regard to what we consider low value care. Many of these things are done with high frequency and are typically not useful. So stress testing preoperatively for stable coronary disease, doing colonoscopies routinely for screening in patients over 75 and onward. And then there are things that we don't do as much of, but they're very, very high cost. So in urology, where I came from, the treatment of very low risk or low risk prostate cancer generally is not warranted, at least in large numbers. So yes, there are going to be some patients, especially younger, in certain situations whose low risk prostate cancer has to be treated. But when you see a preponderance of 75-year-old men with very low risk prostate cancer getting surgery or radiation therapy, that's an issue. Lumbar fusion for osteoarthritis, obviously fetal oncologic therapies for advanced cancer. These are areas where there's just a lot of spend and very little value. So what do we really need to incent to be successful? So from the specialty side, it clearly is around network fidelity. This is where costs are less. This is where revenue is recaptured by us. Quality is critical, not only gap closures, which some specialists can participate in, but these CAP surveys, it's so critical now to think more and more about patients' experience of care. It's not just for the quality scores, but it's also to keep these patients. They have a lot of options. There are so many now telehealth options. In fact, competition doesn't even have to come into your market for there to be a real potential for losing patients if you're not providing that kind of thoughts around the experience of care. And then there's just unbelievable opportunities in reducing unacceptable variation and low value care. So this is kind of the equation that Jim talked about. This is just a little bit more complex version. Value is going to typically be quality over divided by cost. We got to add service, the patient experience, how they've really sort of appreciate that. But I also think it's really important to consider appropriateness. So back to the prostate cancer example, you could have a urologist do a fantastic job with a surgery for an 80-year-old man with low risk prostate cancer, They could treat him wonderfully. The whole hospital could just help him preoperatively all the way through, and it could be very cost effective. But if it's not appropriate, it's really of no value. And so we always have to think about the appropriateness of therapy as well. I don't want to spend a lot of time on this macro MIPS. I will tell you that one of the real advantages of being in an ACO like THN is that we are in what's called an advanced alternative payment model. And so for years, physicians had to do certain quality work we called PQRS, which was the Physician Quality Reporting System, and various different work around what we call meaningful use and value-based modifier. And the government continued to add these additional programs that were required of physicians in order at first to get a bonus and then subsequently to avoid a penalty. And they finally kind of put all of these in a new program back in 2015 through this legislation called the MACRA, where physicians had to start reporting quality cost improvement and some interoperability, unless you were in an advanced alternative payment model. And so for us, for the last several years, we've been able to get a 5% bonus because of the reporting that THN does on quality, and also because of the risk that THN takes. And physicians otherwise in parts of the country or outside of our community that are not part of our ACO have had to continue to do all of this burdensome work. And if they perform extremely well the last several years, they've gotten less than 2% bonus. So this has been a huge value add for our physicians being part of the ACO. So for specialists, beyond this 5% bonus, we've made for some incentive opportunities. On the primary care side, almost the vast majority of that incentive is centered around gap closure. For specialists, we've really worked, without going into details, on referrals and access and improving that, doing a project around low value care, and being engaged with THN by going to various meetings, watching some of our videos, or reading our electronic newsletter. These opportunities are elective. We don't force or require physicians, at this time anyway, to participate in these in order to stay within THN and have the macro bonus. There are certain specialists who are just overwhelmed or don't feel like much of this is a priority, and so they don't participate as extensively as other physicians who have been real champions and have really led the way in some of our programs. So just to wrap up the last couple slides, again, we really appreciate you participating tonight. So for the onboarding, of course, the first step, which you've completed now, is this live presentation where we've gone over this material. And if you're a primary care provider, we'll ask you to watch 2 videos, one on the CAPS, on the patient experience, and then risk adjustment. And if you're a specialist, the same patient experience CAPS survey video, and then a video on low value care. You obviously can watch the other videos as well. We certainly encourage that, but in order to meet the requirements, those are the 2 videos. And then you are able to participate in the bonuses going forward. And so you can find those, and again, we'll send this out. There's a link for the Triad Healthcare Network. You'll look down here to THN Learn, and there will be these courses that you can take, and there's a simple attestation, I believe. I don't think it's really an exam, but Ginger, maybe you can clarify at the end, but an attestation that you watched the video. And so to wrap up, we're financially responsible for close to $1 billion on the Medicare side of annual healthcare spend, not to mention that we have shared savings in commercial. Someday hope to be participating in Medicaid and taking on our own Cone Health employees, and maybe some of the employees of the other health practices within our community. Undoubtedly, we've made a big difference in how healthcare is delivered in this community. We've clearly improved measurable health outcomes. We hope that we're coordinating care much better and delivering a better experience. We are working to reduce care variation and eliminate low value care. We have a lot of work to still do in that third bullet. We truly believe that working together, we can do much better. We really need you to partner with us. We really ask you to be engaged, and we thank you very, very much for your participation tonight. And with that, hopefully, we got a few minutes for questions. So thank you so much.
We do have a few minutes for questions, and also there is one person that I need to identify. Area code starts 614 and ends in 91. So could that person 614 ending in 91 just identify themselves real quick? I'm sorry?
If it's not in the drawer, I don't know.
Did we get it? Did we identify who 614 ending in 91 is? Matt, Ginger? All right, so if you called in on a phone and your area code is 614 and ends in 91, could you identify yourself, please? We want to give you credit for attending. All right. Well, maybe we'll find out shortly. Okay. I am going to open the floor.
Jim.
And yeah. Yes.
Well, what we can do is when Ginger sends out the meeting materials, if whoever you are with that number, if you just reply to that you were at the meeting, that'd be helpful.
Okay, we'll send that out. That's a good idea, Matt. Thanks. Okay, so everybody, we do have time for questions, which you can either put in the chat box or you could just you're unmuted right now, so you could just identify yourself and ask a question if you have any questions about what THN is about. Okay, so I'm not hearing anything except some background noises. So once again, I'm going to echo what Dave said about thank you for attending. Thanks for your participation in THN. Welcome to our community, and we look forward to working with you over the next few years. So y'all have a good evening, and again, thanks for your participation tonight. Have a good evening.